Diabetic ketoacidosis (DKA) is a condition associated with high blood glucose, usually more than 18 millimoles per liter, which nonetheless is unavailable to the body tissue as a source of energy. The fat is therefore breaking down as an alternative source of energy, releasing toxic chemicals such as ketones as a byproduct. Additionally, there is severe dehydration and electrolyte imbalance in DKA, especially low potassium, and is a common cause of death among many diabetic patients. It often occurs in type 1 diabetes patients, but may also occur in type 2 diabetes. In contrast, the hyperosmolar non-ketotic state as hung in diabetes occurs primarily in type 2 patients and is similar in its clinical presentation to diabetic ketoacidosis in many respects. The major difference, however, is the absence of a significant amount of ketones in the urine, usually trace or class 1, and the presence of severe dehydration. The management of this condition is similar to that of diabetic ketoacidosis. So the causes are severe deficiency of insulin, interruption of anti-hyperglycemic therapy, usually for financial reasons or for alternative treatments, stress of intercurrent illness, for example, infection, myocardial infarction, strokes, surgery, complicated pregnancy, among others. So the symptoms are polyuria, polydipsia, nausea, vomiting, abdominal pain, alteration in sensorium or collapse. Those are symptoms of infection or other underlying conditions. So the signs that are usually elicited are dehydration, dry skin, reduced skin tegel, sunken eyes, and deep and fast breathing, low blood pressure, fast and weak pulse, fruity breath, a smell of acetone, confusion, stupor or unconsciousness, evidence of infection, recent surgery, stroke, among others. Investigations: random blood glucose, usually more than 18 millimoles per liter, urine glucose, usually more than 3 plus, and urine ketones, usually more than 2 plus, and blood urea and electrolytes, usually low potassium. However, if in renal failure, urea and potassium levels may be high. Blood film for malaria parasites, full blood count, raised white cell count would suggest bacterial infection. Urine culture, blood culture, chest x-ray for pneumonia, arterial blood gases, electrocardiogram to identify hypokalemia, and in adult patients to exclude acute myocardial infarction as a precipitating factor. So the main treatment objectives are to replace the fluid losses, to replace the electrolytes losses, especially potassium, so to replace deficient insulin, and to seek the underlying cause and treat appropriately. Pharmacological treatment. Let's look at the management of diabetic ketoacidosis. The regimen for managing diabetic ketoacidosis in adults. So adults, initial management, you monitor blood glucose hourly, and you monitor the urine ketones twice daily. That's when the blood glucose and urine ketones test results are 18 millimoles, greater than 18 millimoles per liter, as if the blood glucose levels are greater than 18, or the urine ketones are more than 2 plus. And also in this case intravenous fluids, the type of fluid you give sodium chloride 0.45%, and the rate of IV infusion. You give the first liter over the first 30 minutes, and second liter over the next hour, and the third liter over the next 4 hours, and fourth liter over the next 4 hours, and subsequently 1 liter every 6 hours, or as required. The soluble or regular insulin, IV or IM, give 10 to 20 units that, and thereafter you administer soluble or regular insulin IV infusion 0.1 units per kilogram hourly, or 5 to 10 units IM hourly until blood glucose is less than 11 millimoles per liter. Potassium chloride infusion is that 2 hours after initiating insulin and sodium chloride infusion, and check adequate urine output more than 30 milliliters per hour, and place 10 to 20 millimoles potassium chloride in 500 milliliters sodium chloride 0.9%, and run the IV infusion over at least an hour. So when the blood glucose is less than 13 millimoles per liter, you monitor blood glucose every 4 hours, and you monitor urine ketones twice daily. That's after dropping from 18 more than 18 millimoles per liter to less than 30 millimoles per liter. And then the type of IV fluids, if glucose 5%, and this measure is necessary to prevent subsequent hypoglycemia. And the rate of IV fluid infusion, you continue the glucose 5%, 1 liter every 6 hours to meet requirements. Soluble or regular insulin subcutaneously by sliding scale. Also potassium chloride infusion, repeat potassium infusion after 2 hours if necessary, and check blood potassium level twice daily. Withhold potassium chloride if blood level of potassium is more than 6 millimoles per liter. So the initial management and maintaining management, come to regular management. That's when the blood glucose is maintained between 6 to 11 millimoles per liter, and urine ketones are negative or just a trace. You monitor blood glucose twice daily, pre breakfast and pre supper. And then for IV fluids, you may pause, but it's recommended that patients eat normally as a recommended diet, and you change from sliding scale to twice daily subcutaneous intermediate acting or premised insulin. Okay, so that's the insulin you give, and potassium chloride oral if required. So let's look at the regime for managing diabetic ketoacidosis in children. So initial management, if the blood glucose is more than 18 millimoles per liter, or urine ketones is more than 2 plus, you monitor blood glucose hourly, and you monitor urine ketones twice daily. And the IV fluid, the type of IV fluid, you give sodium chloride 0.9%. The rate of IV fluid infusion, the first hour 50 milliliters per kilogram, the second hour 50 milliliters per kilogram, third hour 7.5 milliliters per kilogram, and fourth hour, and subsequently you adjust fluid rate to meet requirements. So sodium for soluble or regular insulin, IV or IM, you give 0.15 units per kilogram start. Thereafter, you administer soluble or regular insulin, IV infusion or IM, 0.1 units per kilogram hourly until blood glucose is less than 11 millimoles per liter. Potassium chloride infusion, it starts 2 hours after initiating insulin and sodium chloride infusion. And check adequate urine output, should be more than 30 milliliters per hour. You add potassium chloride 0.2 to 0.4 millimoles per liter and per kilogram with a maximum of 10 millimoles in IV fluids, and run infusion over at least 1 hour. So after this, maintaining management, you still monitor blood glucose every 4 hours, and you monitor urine ketones twice a day. As when the blood glucose is less than 13 millimoles per liter. And IV fluids, type of fluid, you give sodium chloride in 4.3% glucose, and this measure is necessary to prevent subsequent hypoglycemia. And the rate of IV fluid infusion, set infusion rate to meet the requirements, and soluble or regular insulin subcutaneously by sliding scale. Repeat potassium infusion after 2 hours if necessary, and check blood potassium level twice daily. Withhold potassium chloride if blood level of potassium is more than 6 millimoles per liter. Regular management, you monitor glucose twice daily, pre-breakfast and pre-supper, as if the blood glucose is maintained between 6 to 11 millimoles per liter. And urine ketones are negative or trace. So the patient, if the patient is eating normally, IV fluids may be withheld, so recommended diet should be eaten in change from sliding scale to twice daily subcutaneous, intermediate or acting or pre-mixed insulin. Also, potassium chloride oral should be given if required. So let's look at a sample sliding scale chart. So blood glucose results following 4 hourly testing. When it's less than 6.0 millimoles per liter, the corresponding dose of regular insulin to administer subcutaneously in adults is none. So no insulin in adults, no insulin in children. When the level is less than 6.0, I think it's between 6.1 to 9.0, you administer 4 units in adults and 0.06 units per kilogram in children. If 9.1 to 12 millimoles per liter in adults, you administer 6 units, and in children 0.09 units per kilogram. If 12.1 to 15.0 millimoles per liter, in adults 8 units, in children 0.12 units per kilogram. And if 15.1 to 18 millimoles per liter in adults, you administer 10 units, in children 0.15 units per kilogram. The example of the sliding scale given above is not a fixed standard. The requirement of insulin for each level of blood glucose measured differs from patient to patient. The corresponding insulin doses may therefore need to be adjusted up or down to suit each patient. For both adults and children, you continue the sliding scale, making appropriate adjustments to the doses of insulin until the patient is eating normally and the urine is free of ketones before changing to twice daily intermediate or pre-mixed insulin. So this may take on average 12 to 72 hours. For the management of hyperosmolar non ketotic state, that's hunk, you treat appropriately. The urgent treatment for DKA and hunk, that's diabetic ketoacidosis and hyperosmolar, are non-ketotic states. Broad spectrum antibiotics for suspected infections could be given, and you treat malaria if suspected or confirmed. Referral criteria: so if there are inadequate resources for managing the patient, to start 0.9% sodium chloride IV and give initial dose of sodium or regular insulin, IV or IM, after confirming blood glucose and urine ketones, and refer to a nearby regional or teaching hospital. And if the patient remains comatose or fails to pass adequate amounts of urine despite management, refer to a regional or teaching hospital for further care.